Good afternoon. My name is Brad Miller, and I'm a pediatric endocrinologist at the University of Minnesota in Minneapolis, Minnesota. And it is my pleasure today to join you to talk about long-acting growth hormone therapy. I would like to thank Professor Hamil for inviting me to be part of a fascinating afternoon, Pediatric Endocrine Academy. These are my disclosures. I'm a consultant for a number of companies that are developing products for children with growth, puberty, and bone disorders. And I will be discussing medications that are not yet approved by some regulatory agencies or are in development. Here are my objectives for this afternoon: to describe current treatment options for children with growth disorders, discuss the rationale for the development of long-acting growth hormone, and describe current status of long-acting growth hormone therapy. First, I'd like to review the currently FDA-approved uses of daily growth hormone, which include growth hormone deficiency, chronic renal insufficiency, Turner syndrome and SHOX deficiency, Noonan syndrome, short stature from Prader-Willi syndrome, intrauterine growth retardation or SGA, and then idiopathic short stature, which is approved in the US but is not approved in many other locations. So for daily growth hormone therapy, we know that there is a good history of information related to treatment, including safety and efficacy. Using the phase 4 registry data, we have more than 500,000 patient years of exposure data saying that it is in general relatively safe, with rare side effects including pseudotumor cerebri, slip capitofemoral epiphysis, pancreatitis, and worsening of scoliosis. We have not seen any increased risk of malignancy while on therapy, and it remains unknown if there are long-term implications of receiving growth hormone therapy during childhood. And I think that the SAGE data raised appropriate concerns about long-term cardiovascular disease, as well as asking questions about cancer or malignancies in the future. And I think it remains unclear as to whether there is an association between the underlying condition for which children are receiving growth hormone treatment, growth hormone exposure, or both. I think it's important to review the fact that children with growth hormone deficiency who have been receiving daily growth hormone therapy are growing very well in response to treatment, but are not actually achieving the adult height that we would expect based upon midparental target height or the average population height. And so we can see in this chart looking at the height at near adult height compared to baseline height in multiple different registries, showing that children have a significant catch-up growth, but don't reach the mean or zero standard deviation scores. And even if we think that the majority of children who are treated with growth hormone have short parents, they're still not getting to the level of their midparental target height. Daily growth hormone therapy does cause a burden on both the patient and their family. And I think it's important from the patient perspective that they can suffer the pain of the injection or suffer from the daily task. Parents are worried about side effects during therapy, and the care providers are concerned that families will forget that daily task. And so they recognize that daily injections are a burden of treatment that can impact both adherence and persistence with therapy. And non-adherence has been documented in multiple different studies, including studies from US, New Zealand, and Spain, and many others. I use these as examples, showing that the non-compliance in one US study was 10% missed more than half of their injections. In New Zealand, 66% missed more than one injection per week. And in Spain, moderate to poor adherence was seen in about a third of patients. And I think it's important to recognize that height velocity standard deviation score, height SDS, and lower IGF-1 standard deviation scores have all been associated with poor adherence based upon whichever measure was used. I think it's important to recognize that non-adherence also increases with time on therapy and is more common in adolescents, and maybe up to 70% based upon some studies. We recently published a paper looking at non-adherence with daily growth hormone therapy and how much it impacts linear growth. This was using adherence data in an electronic medical record pharmacy uh, connection. And we can see that children that were determined as non-adherent had statistically poorer growth at 1 year, and that predicted to lose more height over time. And you can see a difference of about 3/4 of an inch in the less adherent children compared to the adherent children just in the first year of treatment. So I think we have a long history with daily growth hormone therapy showing efficacy and safety. We've also got a correlation between efficacy and improved quality of life, but daily therapy is a burden to both patient and caregivers and is associated with non-adherence that may lead to negative outcomes or insufficient or inadequate outcomes, treatment outcomes at the end of the day. So we do know that long-acting preparations have shown to be successful in other disease states. Hemophilia and type 2 diabetes in adults are good examples when moving from twice traditional regimen of twice or 3 times weekly to once weekly for the hemophilia group showed improvements, and going from daily subcutaneous injections of liraglutide to once weekly also improved adherence, treatment satisfaction, and quality of life. And so there's definite evidence that a longer acting preparation can show success. So looking at the future of growth hormone therapies, we would expect that long-acting growth hormone would improve adherence in patients on therapy, thereby increasing the potential for better outcomes. And I'll talk now about a number of different technologies that have been used to create long-acting growth hormone preparations and a few select long-acting growth hormone molecules. So the first question is, how do we make an injection of growth hormone last longer? We can either delay its absorption from the subcutaneous space, and that has been done by incorporation into microspheres, slow the clearance from circulation, and polyethylene glycol has been used both in permanent pegylation and reversible pegylation. We can use a fusion protein where the growth hormone is modified by addition of other proteins, or we can modify its binding to serum proteins such as albumin. I think the ideal characteristics of a long-acting growth hormone is that it would provide all the benefits of naturally secreted growth hormone. The free growth hormone molecule would reach all the target tissues. It would be administered in a small volume with a small needle and a user-friendly device. Ideally, we would be able to store it at room temperature, and that the pain profile of the injection would be comparable to daily growth hormone, and other safety parameters would be comparable. And lastly, a lack of immunogenicity. When you modify the growth hormone molecule, does that change its immunogenic profile and impact therapy? So the history of growth hormone is presented in this diagram showing that growth hormone therapy began in 1958. And even in 1979, there were studies looking at trying to make injections less frequent by using a growth hormone gelatin. The recombinant human product was approved in 1985 for growth hormone deficiency. And in 1989, Nutropin Depot was approved in the US for pediatric growth hormone deficiency, but was only on the market for about 5 years because of subpar performance, but also difficulties in manufacture. Since 2009, Nutropin Plus has been available in Korea. Since 2014, Jintrolong, a pegylated molecule, has been available in China. And more recently, Sogroya or somapacitan was approved for long-acting growth hormone in adults. Skytrofa or Lonapeg somatropin approved for long-acting for pediatric growth hormone deficiency, and Nagenla or somatrogon recently approved in Canada, Europe, Australia, and Japan. So we now have new options for the treatment of children involving long-acting growth hormone therapy, and I'll talk a little bit about some of the data behind each of these products. So I'll start with somapacitan. Somapacitan is a modification of the native growth hormone molecule with a single point mutation to which is added a human albumin binding moiety, which is a uh, acyl binding cassette, if you will, so a long hydrophilic fatty acid that binds to albumin in a non-covalent way. So essentially, it interacts with the albumin in the circulation to slow release of the growth hormone from the circulation. So there has been similar technology used in insulin Detmer, insulin degludec, and liraglutide and semaglutide. So the modification adds about 1.3 kilodaltons to the size of native growth hormone. So I'd like to present the phase 3 trial data, which I presented at the Endocrine Society just a few weeks ago. And in this trial, 200 prepubertal naive children were randomized 2-to-1 to receive either once weekly somapacitan or daily growth hormone. The data that I'll present is the 52-week data. These children continue in an extension study for receiving once weekly product to see for both safety and efficacy. So the annualized height velocity at 52 weeks is shown in bars in this part of the slide. But the numbers, somapacitan children receiving once weekly somapacitan grew 11.2 centimeters per year, and the daily group grew 11.7 centimeters per year for a negative 0.5 centimeter per year difference. And this was satisfied the criteria for non-inferiority. Additionally, phase 2 results, children that received 0.16 milligram per kilogram per week up to 3 years have shown superior height SDS gain of plus 2.7 standard deviation score compared to children receiving daily growth hormone of 2.1 with no new safety concerns. Somatrogon is a fusion protein where 3 copies of the human chorionic gonadotropin C carboxy-terminal peptide have been attached to the ends of the growth hormone molecule, with 1 at one end and 2 at the other. And it increases the molecular weight of the molecule about twice, so that's about 41 kilodaltons. To show you the clinical trial data, again, randomizing children 1-to-1 in this situation, somatrogon at a dose of 0.66 milligram per kilogram per week, compared to the same dose of genotropin of daily growth hormone, as has been in other clinical trials. Those children grew 10.1 centimeters per year receiving somatrogon and 9.78 centimeters per year receiving genotropin. So we can see that the height difference was non-inferior again in this part of the graph here, showing that children responded well to once weekly somatrogon, and again had a similar safety profile to daily growth hormone. Lonapeg somatropin is a recombinant human growth hormone that has been attached to a transcon carrier by a transcon linker. After it is injected into the body, that linker is cleaved, releasing native growth hormone, so an unmodified molecule that can then interact with the receptor, and the PEG molecule is then cleared by the kidneys. In the phase 3 height trial, 161 children were 2-to-1 randomized to receive either once weekly Lonapeg somatropin at 0.24 milligram per kilogram per week or daily growth hormone at the dose that has been shown in other trials. And we can see that children receiving Lonapeg somatropin grew 11.2 centimeters per year compared to daily growth hormone at 10.3 centimeters per year, with a estimated treatment difference of 0.9 centimeters per year, which was statistically superior over daily growth hormone therapy. And so again, we can see that there has been non-inferiority shown for Lonapeg somatropin, as well as statistical superiority. And in additional phase 3 trial results, there has been demonstrated continued growth improvement up to 2 years in their extension trial with no new safety concerns. So I'd like to compare the different molecules that are currently uh, excuse me, either available or um, uh, currently being evaluated for approval. So we have the Lonapeg somatropin, reversible pegylation, somatrogon fusion protein, and somapacitan with acylation that increases binding to albumin. Lonapeg somatropin molecular weight is not modified when we look at the growth hormone that actually interacts with the receptor. Somapacitan is modified a small degree, and somatrogon has a larger molecular weight. The dose, I think when we look at the different molecules, we have to not think about the daily dose, even in milligram per kilogram per week, because these are new molecules. And so the doses are different, and you'll have to look at each dose, each product, to make sure that you're adjusting the dose relevant to that product. I think in height velocity on the long-acting growth hormone, we saw similar growth velocity in each of the three long-acting products that was similar and non-inferior to the daily growth hormone molecules. After 2 years, we can see a delta height standard deviation gain of plus 1.5 in the Lonapeg somatropin group and plus 2.2 in the somapacitan group. And we don't have that data available yet for somatrogon. The average IGF-1 standard deviation scores while on treatment, I think, is an important question from a safety and an efficacy perspective. And they were slightly higher in Lonapeg somatropin and somatrogon than we saw with somapacitan. So I think it'll be important for us to look at those differences as we start to see real world use of these products. So there are also some unique concerns that could arise with the long-acting growth hormone therapy. I mentioned earlier that there are potential effects related to the modified growth hormone molecule. So when the molecule is modified, whether it's reversibly pegylated, a permanent modification to add an acyl chain, or a fusion protein where the CTP chain remains attached, does that ultimately limit access of the modified growth hormone to the target tissue? And I think the fusion proteins have a higher risk of this because of the large size, but the clinical data is showing us that the molecule gets to the target tissue based upon the growth response. So are there some other issues related to adipose tissue access and lipolysis, access to the growth plate, or other challenges? Are there fusion protein specific effects? So I think that's also a question. Whenever you modify a molecule, do you change its safety or efficacy profile? Will a larger injection volume be necessary? And I think that's an important question. We're giving doses once weekly, but does that mean a child has to take 2 shots once a week or 3? Or are they able to get the same dosing volume that they otherwise would? And that question, I don't think, was encountered very much in the clinical trials because the children were prepubertal and in general smaller, younger. And so that is less of an issue than when we have real world data in pubertal children, for example. I think there's going to be an issue of lack of experience with new therapy that will change with time as investigators and prescribers start to use each of these different products, assuming they all become available. Then there will be a learning curve. Lack of knowledge of dose adjustments is one of those categories. So currently, when we're using daily therapy, we may adjust the dose based upon their weight, their height velocity, and their IGF-1 levels. Or we may just use their height velocity with the weight as the calculator. So I think how we do that with the new molecules will also be important, because when you're in a clinical trial, you dose exactly as the clinical trial requires. You don't have the opportunity to individualize based upon the growth response, the IGF-1 levels, or any other nuances to the child's condition. There are potential differences in the growth response and metabolic activity of growth hormone due to the lack of pulsatility. So we're taking a molecule that is very exquisitely regulated in the body with multiple pulses throughout the day, most of which happen at night. And we're now giving it once a week with one big pulse and then a slow drift down to baseline. And that's actually what daily growth hormone looks like as well. It's just going to be a narrow, daily growth hormone is not physiologic. It's just a narrower pulse that we're giving. And it's been shown to provide all of the growth and metabolic effects that we've been pursuing for both children and adults. So I think we'll see that with long-acting growth hormone as well, is we're showing some of those benefits, but are there some that are not impacted because of the metabolic difference? There's a potential increase in risk of malignancy due to persistent elevated levels of growth hormone and IGF-1. I think this is a small concern because with daily growth hormone, we are already at times achieving those higher values and sometimes persistently. But I think it's an important question that we need to answer over time is, does that even transient period where the growth hormone or IGF-1 level may be elevated in the first couple of days after the injection before it drops down into the goal range and then again even lower, does that change the potential risks, either metabolic or long-term? Monitoring IGF-1 is going to be an important question from a safety and an efficacy perspective. And I was fortunate enough to participate with a working group with lonapeg-somatropin and their model to look at how IGF-1s behave after treatment. So you can see that the IGF-1 standard deviation score has a nice curve where it comes back down to baseline at 7 days. You can see a flat region here between 1.5 and 3 days before it starts to come down. With that group, we developed a chart that you can look at to actually say, if you know the time and day of the dose within a half day and the day and time of the lab, you can actually calculate your average IGF-1 during the week, which I think is going to be the best outcome marker for efficacy, as well as potentially for long-term side effects. Whether or not the peak is relevant to either safety or efficacy is also important. And I think we have to capture that information. But these kinds of algorithms or calculators, if you will, do allow you to also calculate what the peak is with similar methodology. So which children may have an increased risk of complications with long-acting growth hormone? So how do we pick our patients? So first of all, I think children with hypoglycemia related to severe growth hormone deficiency, either congenital panhypopit or isolated congenital growth hormone deficiency, have a higher risk of hypoglycemia. And since there are several days where growth hormone values will be lower or almost undetectable before the next injection, would children be at risk of a hypoglycemic event and seizure during that window because of the lower levels of growth hormone? It's theoretical, but it's an important consideration for your patients. I think it's also a question as to whether those children might not be able to be dosed once weekly and might need it every 5 days or every, twice a week or something like that in that very small population where this is relevant. I already mentioned the cancer survivors with the theoretical risks of transiently elevated growth hormone and IGF-1 levels. I think it's an important point for us to make for our cancer survivors that are on growth hormone therapy, that daily growth hormone has some risks that we still don't fully understand. Long-acting growth hormone has some different risks, and make sure that they're informed if you are considering long-acting growth hormone therapy as a replacement for those children with severe growth hormone deficiency. So which kids are the best candidates for long-acting growth hormone therapy? And I think the children with high risk of poor adherence, those who have previously demonstrated non-compliance, those children who have complex social situations, whether that's two-parent household or um, uh, low socioeconomic status, low parental education, all of those things that we attribute to increasing the risk of poor adherence. Also, complex medical needs, including multiple concomitant medications. If they're already taking other injections or a lot of other medicines, it's easier to forget a daily injection. Adolescents, I think, is a key population here, though I think if they have poor adherence with daily, they may also have poor adherence with long acting. And then naive children, all of the studies have been done in naive children. We've shown efficacy and safety in that population. So we have data supporting them starting, but I think each provider is going to make that decision for themselves of which population do we start with. I think we need long-term safety and efficacy data, which I've mentioned earlier, due to the long-term questions about cardiovascular and neoplasia. We also want to know if adherence is actually better. We'd like to capture some near adult height data, and we'd actually like to know whether long-acting growth hormone could be superior. Maybe we'll have better outcomes than daily, whether it's because of compliance or other factors. And so we need a long-term safety program, and I am one of a group of people that is working to develop one called GlobeReg, which is an effort from multiple pediatric endocrine organizations. I am the representative from the Pediatric Endocrine Society. Lars Savendal is leading the effort from European Society for Pediatric Endocrinology, and we are partnering with multiple other societies around the globe. So we anticipate going live at the end of 2022 with a novel long-acting growth hormone therapy independent registry. You can get more information by going to the website and inquiring about participating. So to summarize, I think we have a lot of evidence that daily growth hormone is safe and effective. Adherence to daily growth hormone has been suboptimal with frequent dose omissions and premature treatment cessation. We've had a number of different technologies that have been employed, with some once-weekly long-acting growth hormone products approved in different countries and others still undergoing clinical trials or awaiting approval. Data from the recent studies suggests that long-acting growth hormone preparations hold promise for achieving clinical efficacy while maintaining a good safety profile. Because of the variability of the pharmacokinetics and pharmacodynamics of each product, we're going to have different monitoring and dose adjusting paradigms for each preparation. And then lastly, I think we have long-acting growth hormone promising improved long-term efficacy, and we need to have those long-term registries to continue to capture safety and efficacy information on these new products. So once again, I'd like to thank Professor Hamil for inviting me to participate. I'd like to thank the sponsors of the program, and I look forward to your questions. Thank you.